One of the skills a paramedic has to learn how to develop, and not just a paramedic, but emergency physicians, cardiologists, many other practitioners, physician assistants, nurse practitioners, the skill of EKG interpretation or ECG interpretation. It's used interchangeably. It's a very important skill, and to be a true master of ECG interpretation, you really have to understand the physiology of the electrical conduction system within the heart. And it might sound a little intimidating at first, but once you start diving into cardiac anatomy and physiology and the electrical physiology of the heart, you're going to see that things start to make a little bit more sense. So electrophysiology is the term used to describe what I'm talking about, the electrical conduction system within the heart. The mechanical pumping action of the heart that we know causes a pulse is very dependent on that conduction system and can only occur in response to an electrical stimulus. This impulse causes the heart to beat because of a series of complex chemical changes within the myocardial cells. And then we call that depolarization and repolarization. And depolarization is the process of discharging resting cardiac muscle fibers, so muscle fibers at rest, by means of an electrical impulse that stimulates contraction. So, almost like you picture someone getting shocked by like a cattle prod and causes all the muscles to contract. Sort of similar within the heart, the myocardium will contract based on this electrical stimulus. Myocardial cells are bathed in an electrolyte solution. So there's electrolytes inside and outside each myocardial cell, and chemical pumps inside the cell maintain the concentration of ions, which creates an electric gradient across the cell membrane. You may have heard of the sodium-potassium pump. That's one of those chemical pumps we're talking about. So a polarized cell normally has a net internal charge of negative 90 millivolts. We're going to bring that up again shortly, but so it sits in this negative state of negative 90 millivolts, and then it's going to get charged or changed based on the presence of these electrolytes. When the myocardial cell receives a stimulus from conduction, the permeability of that cell wall changes, and this allows sodium in. Okay, so this makes the cell more positive. So we know we started at that negative 90 millivolts, and then we can actually become more positive, so negative 80, negative 70, negative 60. And then calcium will also enter, which helps maintain the depolarized state of the cell membrane, and you get this plateau phase. This depolarization spreads along the cell until it is completely depolarized, causing a mechanical contraction. And when I say cell, really you can pluralize that and say from cell to cell to cell, because that's how the cells interact. They're excited by the cells around it. Okay, so as that electrolyte shift happens in one cell, the cell next to it will pick up on that concentration change of electrolytes because it's close by, and then that cell will then react, and then so on and so forth. After depolarization, you have to have repolarization, or it can't occur again. So repolarization begins with the closing of the sodium and the calcium channels to stop the inflow of these ions. Potassium channels open to allow the escape of potassium to help restore a negative charge to the inside of the cell. And then sodium ions are pumped out, and potassium ions are pumped back into the cell. Remember that sodium-potassium pump I just mentioned? It's an active transport of these electrolytes because they're not going to move across the concentration gradient because you want to have that uneven gradient. You want more sodium on the outside again and more potassium on the inside. Well, we know the concentration gradient would just like kind of equalize, and you'd have the same amount both inside and outside. So that pump is used to get the rest of it out, and the rest of the sodium out and the rest of the potassium in. And this establishes a proper electrolyte distribution. After the potassium channels close, then the sodium potassium pump helps move sodium and potassium ions back to their respective locations, which maintains the polarity of the cell membrane. So again, the sodium ions and the potassium ions are going to move in the opposite direction until that concentration gradient starts to normalize, and then the sodium-potassium pump will actually help the rest of it get moving. Probably one of the more difficult things to understand is the cardiac action potential. It's a more complex idea, or I shouldn't say idea, it's actually the electrophysiology within the heart that gives us our EKG pattern. And this is really critical in understanding how antidysrhythmics work, because they work based on these different phases. And that's why you'll get certain antidysrhythmics that block certain electrolyte channels that will work for certain arrhythmias, because they work on the different parts of this cardiac action potential, or the different phases, if you will. And there's about 5 of these phases. And you could see here, phase 0 is where the cell depolarizes and begins to contract. Okay, it's a very short phase. We know, for instance, if you're interpreting EKGs, that the QRS duration should be less than 120 milliseconds, and that is ventricular depolarization. Okay, but this works both for the ventricles and for the atria. I want you to consider it for both, okay? Phase 1 is when the cell begins to repolarize, and this is a longer phase, okay? Phase 2 is even longer than that. So phase 1, it'll begin to repolarize, and then phase 2, sodium and calcium will kind of maintain this repolarization state as they flow into the cell, and potassium flows out, and then the final phase of repolarization will occur with phase 3, and then that's where we get back to our resting phase, where we can start again at phase 4, and then go from phase 4 to phase 0, where we get a new depolarization. And I know none of this means anything to you the way I'm explaining it, so I'm going to kind of try to draw it out, and hopefully that will make it easier to understand. All right, so let's move over here. All right, so the cardiac action potential. What I'm going to do is I'm going to draw it out, even though it's already there. We're going to draw it big so we can look at it as it occurs. So right about here, just as that picture shows, we have negative 90 millivolts. Up here, negative 70. Way up here, let's say that's 0 millivolts. Okay. All right, so what we're going to do is we're going to draw what happens. All right, so we said that resting state is right around here at that negative 90 millivolts. All right, so what's going to happen is you're going to go right here with, this is phase 4, and then we're going to have what we talked about, phase 0, where we have that cellular depolarization. All right, so this begins when the cardiac muscle cell receives an impulse, because again, it's going from cell to cell to cell to cell to cell. All right. In the cardiac myocytes. Sodium moves into the cell through sodium channels, causing the interior of the cell to become electrically positive relative to its exterior. Right? It's not actually positive because it's still in the negatives, but it's more positive than it was. So you're having a slow leak of sodium into the cell here, and then once we reach this negative 70, that's the threshold in which the sodium gated channels will open. And allow for the fast, these are the fast channels, and it allows for sodium, if this was a cell, okay, it allows for this sodium to enter into the cell, all right, because usually there's more sodium on the outside, more potassium on the inside, and now we're going to start having some of this shift, all right. The transmembrane potential changes from negative 90 to about negative 70. At this threshold, still more sodium channels open, allowing a rapid influx of sodium, just like I explained, and a rapid rise in the membrane voltage to about plus 30. So we're going to go from this negative 70 to all the way up here. It's crazy. All right? And that is the depolarization, okay? It's almost a completely vertical line. Like if you look here where it shows phase 0, it's almost a completely vertical line. And what they did that's kind of nice is they're showing the QRS above this, and that is where we have what we know as ventricular depolarization, when that sodium rushes in. All right? Just to explain some more, at that threshold, still more sodium channels open. Again, And then at the same time, calcium enters more slowly through these calcium channels. So now you also have calcium that's moving into the cell. Okay, the influx of calcium actually causes the sarcoplasmic reticulum to release calcium for muscle contraction. All right, so now you're getting from the electrical impulse to the physical mechanical impulse. The cell depolarizes and begins to contract. On an ECG, the QRS complex represents phase 0. So as this picture shows, we see a QRS complex, and that's phase 0. Then we have, after that, phase 1. And phase 1 is inward sodium channels close, and the cell begins to repolarize. All right, we said that's a little bit longer of a phase. And then negatively charged chloride ions will actually enter the cell. So chloride is starting to come in, the sodium channels close, and outward potassium channels open briefly, allowing potassium to leave the cell and resulting in a decrease in transmembrane potential. So, all right, so you have potassium normally in the cell, and now sodium and calcium are in there, and we also have chloride is coming in. The chloride is more negative. All right, so that's where we get this little bit of negative here, and then we're going to go into this long phase of repolarization, all right, which is known as phase 2. All right, in phase 2, this is the plateau phase. Okay, it's kind of straight across. It's the longest phase of the action potential, as you can see in the picture. Sodium and calcium slowly enter the cell, while potassium, flows out of the cell. So still sodium and calcium coming in, potassium coming out. So you're getting kind of an equal change in the positivity of that cardiac myocyte. The presence of calcium prolongs the polarization of the membrane, creating a plateau. The contraction ends when the outward flow of potassium exceeds the inward flow of sodium and calcium, and it corresponds to the ST segment on an EKG. All right, so if you look here at phase 2, go up, and you can see phase 2 is where we have the flat ST segment. So even though there's something happening during that isoelectric phase of the ST segment, it's happening in equal distribution, usually, meaning potassium going out of the cell and calcium and sodium going into the cell have an equal change in its polarity. So there's no change in its polarity. Now, what happens when there's some sort of pathology and it causes these channels to leak or not work as effectively, you might see a change in that ST segment. And then phase 3 is going to be the final phase of repolarization, and that's when slow calcium channels gradually close and calcium is transported back out of the cell. Potassium channels open, and the rapid movement of potassium out of the cell causes the transmembrane potential to become increasingly negative. All right. By the end of this phase, the membrane potential has been restored to its resting value, and with repolarization complete, the cell can now respond to a new stimulus and depolarize again. Okay, so and then phase 4 is called the resting phase, and that's kind of like the normal negative 90 millivolt phase as well. All right, so again, at the end, you have phase 3 where we come back down here to normal, and then phase 4, and then slowly you're going to get back, you have those sodium channels open back up, and then you'll hit another state of depolarization. It'll go up, but I have that little cell in the way there. All right, so that's kind of a quick understanding. There is another video in the module that gives a much better, clear understanding of this. This is where we get what we see on the EKG. And again, the repolarization, once you hit the phase 3, that's where we get our T wave. So the end of phase 1 into phase 3 is where we get our T wave from the cardiac action potential. Next, we're going to talk about the refractory periods, and these are periods in which the cell is depolarized or in the process of repolarizing. It consists of 2 different phases. You have the first half, which represents the absolute refractory period, and this is a period of time, kind of from phase 0 to the middle, about to phase 3 of that cellular action potential, in which the ventricles have not sufficiently repolarized, so you can't have another depolarization. Okay, so if we were looking at a QRS, here let's just draw QRS and then a T wave, okay? All right, so we know that from phase 0, that's the beginning of the QRS, to about the middle of phase 3, let's say that's right about here, okay? So that, from here to here, would be considered your absolute refractory period. Absolute refractory period. Right here. All right, and that means you can't have another beat. Even if the ventricles had, wanted to have a little PVC fire, it wouldn't be able to because not enough of the cells have been repolarized. Now, following that, you have, this is all the relative refractory period, okay? Relative refractory period is right here, and that is an area where it's the second half and represents the relative refractory period. This is where phase 3 and the middle of phase 3, about the end of phase 3 to phase 4 of that cellular action potential, and it indicates that some cells have repolarized sufficiently enough to depolarize again. And this is where you can get that R on T phenomenon. R on T phenomenon, where you can have, if you had a PVC hit really early somewhere here in that relative refractory period, you could put a patient into VFib, VTAC, torsades de pointe. That's why a long QT syndrome, where you prolong this whole thing, you're going to get a longer relative refractory period, and these patients are going to be more susceptible to lethal arrhythmias like torsades or VFib. I'm talking more about the conduction system. The conduction system is specialized conduction tissues made up of specialized pacemaker cells. When I say specialized, that means not every cardiac cell is the same. Some are, areas are more densely packed and they respond differently to those electrolytes that we were just talking about. And we talked about the lanes of traffic in the conduction system is the highway, right? And outside of the conduction system, within the heart, you still have back roads. So the pacemaker that I just mentioned is the area of conduction tissue in which the electrical activity arises. It sets the pace for cardiac conduction. It doesn't always have to be the SA node. The heart has like a built-in backup system. The dominant pacemaker is the SA node, or the sinoatrial node, and it receives blood from the RCA. It's sometimes a little bit of blood from the left circumflex. In about 0.08 seconds, or 80 milliseconds, electrical impulses generated in the SA node spread across the atria and advance through 3 internodal pathways, so that you get your atrial depolarization. That's pretty fast. Now, if for some reason your SA node or your sinus node isn't working as effectively, you have a backup system, and then maybe your atria, somewhere else in the atria, will take over. You could have an escape rhythm, an escape atrial rhythm, or a fib, which is when you don't really have a pacemaker, it's kind of erratic. A flutter, it's more of a reentry rhythm, or you could have a junctional rhythm. That's a better backup to your sinus node. Junctional rhythms we know are slower intrinsic rates, but they still function pretty well. Moving on down to the AV node. The AV node is located in the floor of the right atrium, behind the tricuspid valve, near the opening of the coronary sinus. And when the impulse from the SA node enters the AV node, it is delayed for about 120 milliseconds, or 0.12 seconds, before it is relayed through the rest of the conduction system. And that's important to remember because we talked about Frank Starling mechanism and allowing for ventricular filling, for the atria to get all of its blood out. That's why we have that pause in the AV node. This delay it allows the atria to empty its blood into the ventricles and improving cardiac output, right? And about 70 to 80% of the blood in the atria fills the ventricles by gravity. The remaining 20 to 30%, it requires that atrial contraction. The AV junction, including the AV nodes, surrounding tissue, and the bundle of His, also called the AV bundle, conducts impulses from the AV junction to the right and the left bundle branch blocks. So here we have a pretty good picture of the electrical conduction system, and here's that SA node, that right about there. Okay, that's that SA node with that intrinsic rate of 60 to 100 beats per minute. And that's our typical pacemaker. That's the dominant pacemaker. And these are just internodal pathways in between the SA node and the AV node. And then here, going across from the right atrium to the left atrium, that's Bachmann's bundle. And that's what's going to conduct electricity really fast, or depolarization really fast, from the right atrium to the left atrium, so they can depolarize almost at the same exact time. That's why we get one P wave instead of two. Here's that AV node right here. That's where the conduction is going to pause, allowing for ventricular filling. Okay, and this is all known as the AV junction. The His bundle, the AV node, all the surrounding tissue. This is all called the AV junction in this area. Here's your right bundle branch. Here's your left bundle branch. Okay, and then this comes down here, and our Purkinje fibers are at the end of these bundle branches. Now, technically, your left bundle branch has two fascicles, even though it's only showing one, and your right bundle branch has a single fascicle. So your left bundle branch has a lot more of a conduction system. It's got thicker muscle, bigger chamber to depolarize, and that's pretty much the conduction system of the heart. So normally, impulses will pass through the AV junction into the bundle of His, and then move rapidly into the right and the left bundle branches on both sides of the intraventricular septum. If the atrial rate becomes very rapid, then the AV junction can regulate the number of impulses that reach the ventricles. So you could have the atria depolarizing more times than the ventricles, and if you think about how that would look on an EKG, you would probably get more P waves than QRSs, right? All right, so if you had an atrial tachycardia, you could still have a good ventricular rate because of that AV junction. They then spread into the Purkinje fibers, those impulses. An electric impulse spreads across the ventricles in about 0.08 seconds or 80 milliseconds while the ventricles simultaneously contract. It's a very advanced system to allow the atria to near simultaneously contract and the ventricles to simultaneously contract. So it's the most efficient pump it could possibly be. Talked about that backup system, and we call those the secondary pacemakers. Any conduction system component can act as a secondary pacemaker if the SA node becomes damaged or suppressed. And I mentioned how that can happen, but that doesn't mean that every single cell in the heart can be the pacemaker. Don't think of it that way. Any part of the conduction system, so within that highway, for the most part, can become the pacemaker. So the main parts of the conduction system, the SA node, okay, we know can be the pacemaker, the AV junction, the Purkinje network, all of these things. So this would be a ventricular rhythm if it was the Purkinje network. This would be a junctional rhythm, and this is a sinus rhythm. That's where we get the names. You could also have just an atrial rhythm, where it's some other part of the atrial conduction system that isn't the AV junction or the SA node. In addition to your physiologic conduction pathways, you could have an accessory conduction pathway. And this isn't, it's typically congenital. It's not a normal physiological thing, but it's a pathological thing in a way. And it's extra heart muscle tissue that connects the atria and the ventricles, bypassing the AV node. And we just talked about the AV node and how it's important, and it can slow down the atrial rate before it makes it to the ventricles. It slows down that atrial impulse to allow for ventricular filling. So bypassing it isn't necessarily a good thing. You could have something called James fibers. That's the first one. We're going to talk about James fibers. They're in the intra-atrial nodal pathways, or the internodal pathways, and they extend into the ventricles, bypassing the AV node. So they go directly. So if this is our SA node, we have those intranodal pathways. This is our AV node, and then we have our AV junction, bundle branches, and Purkinje fibers, right? So what the James fiber will do is it'll connect this intranodal pathway to the bundle branches or the bundle of His by bypassing the AV node. So you can end up getting a pretty bad reentry tachycardia by doing that. That's called Lown-Ganong-Levine syndrome when you have that, LGL for short. You could also have something called Mahane fibers, and Mahane fibers are in the AV node, the His bundle and the bundle branches. It could be any of those, and they extend into the ventricles and provide a common pathway for reentry dysrhythmias as well. Or another common one that you're definitely going to learn a lot about is the let me erase this. Wolff-Parkinson-White syndrome, where you have the bundle of Kent. The bundle of Kent is typically located between the left atrium and the left ventricle, although it sometimes can be found between the right atrium and the right ventricle. And it enables the depolarization wave to bypass the AV node and trigger early depolarization of a section of the ventricular tissue. And this can cause pretty lethal reentry tachycardias. These simultaneous depolarization events create a change in the ECG tracing called the delta wave. So I'll kind of just draw a heart here. So here we have the atria, and let me do the ventricles. Just get our septum in there. Okay, these are our valves. All right, so typically you have your SA node, your AV node, intranodal pathways, and then down the His bundle branches. And there you go, Purkinje fibers, and you're good, right? That's typically what you would have. Maybe even Bachman's bundle here. That's normal. But with WPW, you may have the Kent bundle, or the bundle of Kent, which is a connection from the atria to the ventricles. It could be on the right or the left. Usually it's on the left. And what happens is the depolarization will go down into the ventricles without slowing necessarily at that AV node, or some of it will, right? So let's say you have normal conduction here. Okay, that's normal conduction. And what is this part right here? Where do we get this isoelectric line, that PR segment? Well, that comes from that AV nodal pause. But what we're saying happens is over here in the left atrium, it's bypassing. We're getting that bypass so there's no AV nodal pause there. So it'll actually start depolarizing the ventricles a little soon, and this is called a delta wave. Delta wave. And that's pathognomic of WPW. You get a widening of the QRS, a delta wave, all right, and a shortened PR interval. So this PR interval is pretty short. Shortened PR interval, delta wave, and widening of the QRS, all indicative of WPW. So the autonomic nervous system in the heart, both the sympathetic and the parasympathetic division of the autonomic nervous system affect the heart. We talked about it before, right? We know that the adrenergic side, the sympathetic nervous system, increases the heart rate, increases contractility, whereas the parasympathetic nervous system kind of slows heart rate. So sympathetic nerves supply specific areas of the heart's electrical system, atrial muscle, and ventricular myocardium. Nerves transmit commands by releasing norepinephrine. That's our neurotransmitter, right? Norepinephrine travels to the SA node, AV node, and the ventricles. So norepinephrine will travel to, all chambers of the heart, basically, to prevent a buildup of lactic acid. The heart speeds up, increasing cardiac output. That's all the sympathetic nervous system, right? Norepinephrine, epinephrine, causing an increase in heart rate and contractility, overall increasing cardiac output. An accelerated heart rate shortens all phases of the cardiac cycle. When the ventricles have less time to relax, less time is available for these chambers to fill adequately, so you get a decrease in that Frank-Starling effect, and cardiac output will overall decrease, and signs of myocardial ischemia might even appear. So you could have a rate-induced ischemia, and that's actually visible on a 12-lead EKG many times. So this image kind of explains where the nerves of the autonomic nervous system will innervate. And you can see from the medulla, you have your parasympathetic nerves, mostly known as the vagus nerve, right? So your vagus nerve, super important. It connects mostly to the SA node, and it does innervate the ventricles, but to a way lesser degree. Okay, so any medication that you're going to give that works on the parasympathetic nervous system is mostly going to be effective when it's an atrial arrhythmia. If we're bypassing the atria, bypassing the AV node, because that's another place where you have vagus, innervation. If you bypass those, then you're going to be using a medication that's not going to be as effective. You need to move on to a different medication that will work on the ventricles. Now, the sympathetic nerves, they connect to the ventricles and the atria, and you get good sympathetic response both to the atria and to the ventricles. So again, just like I said, parasympathetic nerve fibers supply the SA node, atrial muscle, and the AV junction of the heart by way of the vagus nerve. It innervates functional areas, decreases the heart rate. So like when you use a vagal maneuver or Valsalva maneuver, you can actually stimulate your parasympathetic nervous system and cause a decrease in the heart rate. That's an actual treatment strategy that we use to try to break reentry tachycardias. But it's stimulated in other ways as well, increased pressure on the carotid sinus. We don't really do carotid sinus massages in the field because of the risk, of causing somebody to pass out because, you're cutting off blood flow to the brain, or they could have some, lesion or something bad in there that you don't want to mess around with. And then distension of hollow organs such as the bladder or stomach can actually cause a parasympathetic response as well. But that's what we're trying to stimulate through the Valsalva maneuver. If the brain senses that the heart should slow its pace, it sends an electrical impulse down the vagus nerve all the way to the SA node. So the brain says, okay, we need to slow the heart down, as it would when you're doing a Valsalva maneuver that we were just talking about. It'll send that impulse all the way to the SA node. The electrical impulse stimulates the release of acetylcholine, again, another neurotransmitter, and then acetylcholine signals the SA node to decelerate the heart rate. Another acetylcholine molecule will travel to the AV node, ensuring that no additional impulses get through. So think about what that means when you're dealing with dysrhythmias. If you have a sinus rhythm, because it says SA node, or some junctional rhythms, but anything atrial, right? Anything supraventricular, because it also says it works on the AV node. Any of those may respond to both vagal maneuvers, okay, because that works on the vagus nerve, or atropine. It's an anticholinergic, which also works on the vagus nerve by blocking the vagus nerve, blocking acetylcholine. Okay, so those things that I just said would work or could potentially work for supraventricular dysrhythmias would probably not work as well for ventricular dysrhythmias because the vagus nerve doesn't innervate the ventricles that well. It's to a much smaller degree. So here's that visual representation of the vagus nerve coming off the medulla and innervating over here at the SA node. You probably know that the prefix baro means pressure, so it makes sense that your baroreceptors are pressure receptors, and chemo means chemical. Chemoreceptors are chemical receptors, right? So baroreceptors are sensors composed of specialized nerve tissue. They're also known as pressoreceptors, and they're found in the internal carotid arteries in your neck and the aortic arch. All right, so the aortic arch and the internal carotid bodies. They detect changes in your blood pressure, of course. They're pressure receptors. And they generate a reflex response in either the sympathetic or the parasympathetic division of the autonomic nervous system, dependent on the pressure. So if you had in your aortic arch or in your carotid arteries, you had a low pressure, which nervous system do you think would respond? The sympathetic or the parasympathetic? Well, the sympathetic would respond because you have a low pressure. So that feedback loop is saying, all right, let's compensate, increase heart rate, you might get an increased cardiac output, increasing blood pressure. And vice versa. So if it picked up a high blood pressure, it might stimulate your parasympathetic nervous system, in your vagus nerve, and acetylcholine to slow down the heart rate through the mechanisms we just talked about. And then finally, chemoreceptors, as I just mentioned. Chemoreceptors are chemical receptors, and they're located in the internal carotid arteries, the aortic arch, just like baroreceptors, but also you have some in the medulla, and they detect changes in the concentrations of chemicals in the blood, specifically hydrogen, oxygen, and carbon dioxide, and there causes either a sympathetic or a parasympathetic response to these changes. So if there's a change in your hydrogen, oxygen, or carbon dioxide levels, you can get another autonomic nervous system response. And that brings us to the end of video number 2 of cardiovascular emergencies.